Good morning and welcome back. This next segment is on mental and physical health. Talitha and I are sitting closer, and so we've masked up. And in a moment, we're going to hear from a dear longtime friend of mine, Dr. Joe Alcorn. Joe sings bass in Coro Lux, but he is also a doctor of medicine. He is a retired professor of medicine at the University of New Mexico, and he's been keeping us up to date on the novel coronavirus as we hope and pray that we can get back to singing together again in person. Talitha and I may ask the occasional question as lay people if we don't understand everything that Dr. Alcorn said, and you can also write your questions and we will see them on the monitor and can perhaps be your voice here in the meantime. And then as Dr. Alcorn finishes his session, Talitha and I will stay on screen and go directly to our own session on mental health. So here without further ado is my dear friend, Dr. Joe Alcorn.
Thanks, Brad, and I'll ask for the first slide here. We're going to talk about this disease, COVID, today, and especially the title of the slide, which should show up on the screen here in a second, is there light at the end of the pharynx? And I'm going to give a spoiler alert. I believe there is two beams. One is the bright light, I think, that science has shown on the virus itself, with the result of vaccination is now at hand. The other light is maybe more powerful, but maybe more flickering, and that's the light of how we take care of one another and how we mitigate the potential infection itself as a community. The goals of this are to kind of set us up perhaps so we can explore some of these elements more in question and answer form. There's way too much to the virus to talk about it all within a short time. And I'm going to make a distinction from the very beginning between the virus itself, SARS-CoV-2, the severe acute respiratory distress syndrome, coronavirus 2, and the illness, COVID-19. They are two separate things. We'll come back to that. Next slide, please. This is a little cutaway of the virus on the right. You're seeing a cartoon that shows a kind of a capsule with looks like a spring inside. That spring is a representation of the virus's own genetic plan. If it was a human, we'd say it was DNA, and in this particular virus, it's RNA. And the distinguishing feature that gets your attention are those purple drumsticks all the way around this, which is known as the spike protein. That is a feature of all of the viruses in this family of coronaviruses. In fact, it was because under a microscope they looked like little crowns that whole family got its name as coronavirus. They all share this spike protein, and the spike protein is integral to the way this virus works. Like all viruses, it cannot survive outside of a cell. It can't survive on a countertop or a surface. I should say it can't replicate. It can survive for a period of time, but it can't reproduce. It has to get into a cell, some kind of living cell, and hijack the machinery and take over the goodies in order to manufacture more copies of itself. Oops, let's go back to that slide. We're not quite done. The SARS family used to be, the coronavirus family used to be kind of a sleepy backwater of virology because it was only thought to include viruses causing the common cold, which can be very annoying, even problematic for a singer perhaps, but isn't really a public health menace. On the other hand, in 2003, a severe acute respiratory distress syndrome arose that proved to be from a coronavirus. That was then called SARS-CoV. It was quite lethal. About 10% of people died, but luckily it wasn't terribly infectious and kind of petered out after several thousand cases around the world. But it jump-started research of a more serious nature on this virus and therefore understanding of some of the mechanisms we're about to talk about. 10 years later, MERS, a Middle Eastern acute respiratory syndrome, arose, also turned out to be a new coronavirus, even more lethal, one death out of every 3 infections, but luckily not very infectious. And so when this third virus arose last year, about 13 months ago, I guess, there was already some interest in this group of viruses and how to deal with them as a consequence. The other point to make from this slide is, of course, the seriousness of the impact of the virus is not just how lethal it is. SARS-CoV-2 does not kill 1 out of 3 or even 1 out of 10, but it is so much more infectious that the total number of people infected, and therefore the total number of people with the worst outcome, is just substantially higher than for these other viruses. Now let's move on to that next slide. This may be the most important slide conceptually to set us up for questions and answers. I don't have a cursor that I can use, so I'm going to just walk you through a counterclockwise cycle starting at the top where you see a couple of little coronaviruses with those little crown spike proteins descending on a cell. The cell is this bottom 2/3 of the slide. And you can see that that coronavirus, one of those spike proteins, is fitting into this little cartoon receptor, and thereafter is being granted admission to the cell. Cells can't just let anybody in, right? They don't want home invasion any more than the rest of us. They regulate who gets in and out, mostly by specific receptors, and that means a particular lock to which the entity that's being granted entry has the key. And this receptor on this cell is a receptor for a molecule called ACE. So you'll see ACE receptors sometimes. Don't have to talk about that. It's kind of a working class molecule to do with blood pressure control, no drama. But in this case, the virus exactly mimics that normal molecule. So the key is turned and the cell membrane opens and the cell expects to see ACE, and instead here's this virus. So now the virus has done what it needs to do. It's got access to all the goodies inside the cell. And you can see at about 9 o'clock there, it's sprung out that RNA, that genetic message. And at about 7 o'clock, it's reproducing itself. And at about 6 o'clock and 5 o'clock, you can see that RNA is now master planning the construction of more virus. The cell is under its thrall and is putting together more spike proteins, and finally at the 3 o'clock level, it's manufactured more of these viruses, which are leaving the cell and going out into the environment. The process probably takes 8 or 10 hours, but it's not just one virus. A single cell probably results in the manufacture of somewhere between 1 and 3,000 viruses. So the cell is killed in the process, and the virus emerges into the environment, either to go to more cells and do the same thing, or to be coughed up, spit up, somehow brought into contact with other people. You can imagine this virus, or think of this virus really as only having a couple of choices. One choice is to resume infecting other cells. That's like so many bad choices. It's got a short-term benefit. The virus gets to replicate. But in the end, if the virus kills the host, that's the end of the virus. In fact, if the host's immune system kills the virus, that's the end of the virus. The only way the virus can survive to another day is to get out and infect other people. And so that's one reason that keeping it from infecting other people stops the virus in its tracks. Let's move on to the next slide. This is just the most technical thing I'll show you, and it's really just to impress you that the spike protein and that receptor are not little tinker toys. Up in the northwest quadrant here, we have the virus. We're just seeing a little bit of the membrane or the outer surface, and that spike protein is sticking out of it here. It's got green and purple sort of aspects. It's a complicated protein, not just a little tinker toy with little red sugars hanging off. And then the host cell, us, we are on the very bottom. That's our membrane with our little ACE receptor sticking up. And so you can see in that little box, it's a hatched kind of a box, a place where green meets blue, where this green part of the spike protein hits this blue part of the ACE receptor, and that is where the action is. If that happens, if the receptors meet, and if it's pretty stable, the spike protein doesn't fall off, the cell doesn't jiggle and fall off, then that's how the key that's going to open up that host cell and let that virus get inside. That little area is called the binding domain, and that's the key to getting access into the cell. Go ahead and show me the next slide. Remind myself what's coming next. Yes. So think then, at this point, having just talked about the virus alone, think how quickly we've come to the ability to show you that slide. This virus was first isolated from human beings in the first part of January last year, and within a week, its entire genetic code, that plan, had been uncoded. Within a month, that binding domain had been discovered because, if you ask a fifth grader with the information we have so far, what should we do? He'd say, or she'd say, keep that virus from getting to that receptor. And that's exactly what the science in virology began to do. And within a couple of months, the ability of blocking that interaction with antibodies in particular had been demonstrated in animal models to prevent disease. So literally within 2 months of discovering this virus, which is really unbelievable. I mean, my life with hepatitis C included knowing there was a virus that took 20 years to isolate and 20 more years to get drugs for. And here we are within 2 months with the vaccine trials initiated and 6 months for a vaccine. There may be more to talk about there with questions and answers later, but for the moment, let's say that that bright light of virology on this virus has been incredibly effective and incredibly quick. Next slide, please. On the other hand, there is the illness, COVID-19, and that's a whole different level of complexity. We hear people extol science for its work on vaccines, rightly so. We also hear people frustrated with science because there's so much about the illness we do not know. And that's simply because if you take the simplest virus and drop it into a human being, suddenly you're no longer in a nice clean test tube, you're in a person with coexisting conditions or underlying differences in fitness and nutrition and immune function and behavior. Turns out to be rather important. And those are just the individual characteristics. This epidemic, you can go back for a sec, this epidemic has also demonstrated to us that there are some people that are more vulnerable than others by the nature of their exposures, by the nature of their work, and as it turns out, disproportionately people of color. That's a whole other social dimension we won't talk about today, but it's extremely important. Now the next slide. So if you wanted to look at how the disease is actually created by the virus, you have to start with where are these receptors, because that's where the virus is going to go. There are these receptors in the GI tract. Maybe sometimes that's relevant to the acquisition of disease. You could get the virus down the GI tract, and if the acid in the stomach didn't kill it, it might get through. Might happen. There's really no direct way to get from the outside to the inside kidney, from the outside to the inside liver or blood vessels or heart, but the lungs and the respiratory surfaces are full of these receptors. And so the way this virus seems to be transmitted is by being inhaled and interacting with the receptors on the lining of the lungs and the tubes that lead down to the actual lung surface. Next slide. This is just a cutaway, like a little Egyptian guy who's can breathe in from above, and the virus, along with the air, transmits through that large trachea down into the smaller and smaller aspects of the lungs, down to that green area. And we're going to look at the green area here in a second. That's where the actual lung business takes place, where the little sacs we call alveoli actually exchange oxygen with the bloodstream. Let's go on to the next slide. This is a little cutaway of one of those little sacs. You're seeing air in and air out on the top, and the lung sac looks like a little light bulb in this case, but it's gotten so thin that you can see at the bottom of it, it's just one cell thick. And then below it, like a little encircling pink structure, is the blood vessel, which is up so close to it. It's actually pulled apart here just for demonstration purposes, but so close that that single cell of the wall of the blood vessel and a single cell of the wall of the lung are literally right next door to each other, right adjacent one to another. So oxygen can get in and carbon dioxide can get out. It's necessary for function. But now imagine that you have a lung cell infected by virus, 3,000 copies, cells destroyed. You are just literally nanometers away from the blood vessels. And even though the virus maybe got into the lungs and started in the lungs and provided symptoms mostly in the lungs, it doesn't take much destruction for it to get in the blood. And then it can get to the kidneys and the heart and the muscles and elsewhere. So you might not expect those organs to be affected initially in the viral infection, but if it goes on long enough unchecked, this is how access is acquired, and this is how the virus takes off to the races. Next slide. There is defense. You've got bristles in your nose and mucus along the lining of the trachea, and this is the surface of the lungs. This little lawn is all moving, trying to push the mucus upward and out and away from the lungs. So not every viral particle you breathe in can possibly get in to cause infection. Probably takes 1,000 or more before enough evade the defense to actually get started. But nevertheless, that's how it happens. There's a dose of virus that's enough to overcome the defenses, and the probability of infection rises as that dose increases. Next. And I'm going to skip this one just in the interest of time. And I think I'll also skip this one in the interest of time. So needless to say, the viral illness begins as an early lung phase where the virus is in the respiratory system. But if it goes 4 or 5 days and the immune system doesn't shut it down, now it can extend to organs elsewhere. And again, another 4 or 5 days without effective shutdown, the body's response gets more and more hysterical, you might say. There's more and more collateral damage. You read in the paper sometimes a cytokine storm. That just means the response of the immune system has begun to do damage on its own. And so this viral illness progresses through stages if it progresses in that fashion. Best treatment of all, of course, is to avoid being infected in the first place. Next. Now, if you were going to search out this image on the internet, you'd Google it under sneeze, but it could be a high B. And I say that because a sneeze and a loud voice singing are almost the same in terms of how many particles from the lungs they project outward. Next slide. A cough, maybe 3,000 droplets. Now we're talking about droplets as things we can see that can be detected easily by light sources. So that's down to a certain size. There are smaller particles that you don't see by these mechanisms that define the numbers I'm going to show you. And we know there are small particles even when you breathe. After all, when you breathe out on a cold day, you see your breath. Unless you're boiling, that is not steam. Those are the tiny particles of respiratory origin that can include virus. To begin with, this virus, SARS-CoV-2, was thought to be like SARS, the virus isolated 20 years ago, where people weren't infectious unless they were having symptoms. But with this virus, that's not true. You can be infectious before you have any symptoms at all, and you can eject virus in the form of droplets. Luckily, the bigger and more visible they are, the heavier they are, the more quickly they fall, and within 5 or 6 feet of you, most of them are probably down on the ground out of the way. But on the other hand, if they're very tiny, if there's just a little bit of water that could evaporate in the air, it could leave the virus just floating in the air itself. Not in abundance, but nevertheless sticking around in the air. And so it looks like if you're breathing, you probably are putting out 20 or so viral infection particles in a minute. The numbers are approximate here, and it might take 1,000 to cause an infection. So if you were breathing in everything somebody else who was infected was breathing out for 50 minutes, you might have enough to have your own infection. If you were breathing in everything that person was putting out when they were talking, it would take you 1/10 of the time, because the spoken word is a couple of hundred particles per minute. Obviously, if they diffuse into a huge space, you're less likely to breathe them all in. Nevertheless, that's the nature of speaking, and singing simply ramps it up by another order of magnitude. Higher volume. As this audience knows, the melody is in the vowels, but the meaning's in the consonants. And if you're exaggerating your percussive P's and your fricatives, you are in a say it, don't spray it situation, right? And so singing turns out to be just as effective as coughing and sneezing in spreading this virus. Next slide, please. So how do you stop it? You stop shots on goal. No team ever lost if you could keep the enemy, the opponent, out of the penalty box. If you couldn't have enough distance that they couldn't make a shot, then you're pretty likely to avoid loss. Next slide. Of course, not everybody plays soccer. It's the same idea, though. Out of the box in soccer is like in the paint in basketball. It's like in the red zone in football. The idea is, if you can keep the opponent from getting to a score, in this case, the virus into your lungs, into your cells, then you have a pretty good chance of avoiding the infection. Next slide. Do we have 5 minutes for a video, or should I move on here? I'm not watching the time carefully enough. This is a video of masks and how they work, which I think is worth knowing. Brad, do you have any?
Respirators and
Okay,
face
here we go.
prevent harmful particles from getting into your lungs, and what makes them more or less effective at doing the job they're designed for. Face masks and their higher performance cousins, respirators, are designed to prevent users from inhaling harmful airborne particles, whether these are dust particles or pathogen-carrying droplets. They can also reduce the amount of harmful particles someone expels into the air around them, especially through coughs and sneezes. But the physics behind how they work is not necessarily that obvious. It's tempting to think of the filter material that respirators and face masks are made of as a microscopically fine sieve that physically blocks small particles from entering your mouth and nose. Unfortunately, the science isn't quite this simple, though. The materials that commercial respirators and face masks are made of usually consist of tangled mats of fine fibers. These create convoluted pathways that the air you inhale has to pass through, along with any particles and droplets being carried along by it. For particles big enough to be seen by the naked eye, these fibrous mats actually do behave a little like a sieve by physically blocking them from getting through, but this is pretty much where the comparison ends. This is actually good news, as a sieve that was fine enough to physically block the particles that you can't easily see, and the ones that are often the most dangerous, would be near impossible to breathe through. For many of these particles, it's their inability to follow the convoluted pathways through the filter material that leads to them being captured. To get a handle on this, imagine a car speeding along a winding road. The car fits easily on the road, but if it's going too fast, it won't be able to navigate the bends, and you just know that at some point it's going to crash. It's the same for small particles speeding through a filter. As the air twists and turns, the particles can't keep up, and ultimately they end up crashing out and being caught. Because of their inertia, which, just like the car, depends on how massive they are and how fast they're going, they can't stay the course. But how about the smallest, lightest particles, those that can easily slip along the winding path the air takes? Amazingly, these are also captured efficiently by a well-designed filter material, but the way they're captured is very different. Because really small particles have so little mass, they dance around as they're bombarded by the air molecules surrounding them. And as they dance, they end up colliding with and being captured by the material the respirator or face mask is made of. Because of the way diffusion-based capture like this works, the finer the fibers are that the material is made of, the more effective they are at collecting these fine particles. So much so that some filter materials are made of a web of incredibly thin fibers that are held in place by a mat of much coarser ones. And then you have the middle-sized particles, the ones that are too small to be captured because of their inertia, but too large to be captured through diffusion. These particles are usually a little smaller than 100th the width of a human hair, and they are the hardest to remove. This is why respirator and face mask manufacturers test the efficiency of their products with particles in this size range, those particles that are just the right size to slip through and make it to the other side. In a well-designed respirator or face mask, layers of non-woven materials create sufficiently convoluted pathways that the vast majority of these middle-sized particles are removed from the air. But for a respirator or face mask to be effective, it also needs to allow the user to breathe freely. Pack the fibers too tightly and not enough air can flow. On the other hand, pack them too loosely and most of the particles just pass straight through. How do
So an important thing to see, mostly so people understand that if we're trying to prevent the infection, you can keep the other team out of the box by distance, right? You can put on a mask, which is the best way to have a barrier, and the masks are not just sieves. I think one of the masks have been weirdly politicized, but one of the concerns or rumors, I guess, has been that they're merely sieves, and since the virus is so tiny and can pass through, I wanted you to see that that's not the case. They're more like obstacle courses. Of course, Air circulation is huge here. As we were saying before, if you're breathing in everything your friend breathes out, you're at risk. But if what he breathes out or she breathes out diffuses into a large space and is blown away from the wind, it's like blowing a soccer ball away from the goal. And maybe one of the reasons things are a bit worse in the winter for most respiratory diseases is that things are drier, and those little particles that you might expel evaporate more quickly and leave virus in the air more readily. But each of these is a layer of defense: distance, mask, circulation. No one is perfect, but if you put them all together, you have your best chance of protecting not only yourself, and this is important, but protecting other people as well. Now, there are exceptions, just the same way Lionel Messi might, bicycle kick it in from midfield, totally unexpected. A sneeze in the right circumstances can exceed 6 feet by a long way, 7 or 8 meters, 20, 25 feet. There are exceptions, but if we're trying to play the odds, you layer on the defense, you maximize your chance of avoiding this disease. I think we need to skip this. Now, let's run it just for a few seconds, 10 seconds. These are vocal cords in action. I can't show you on the cursor.
If with all your hearts you truly seek me,
Notice the white
ye
spot.
shall ever surely find me. Thus saith our God.
The vibrating vocal cords. Those little white spots are not flecks of something on the vocal cords and on the pharynx here. That's glistening, that's light reflected, because this whole area is covered with mucus. And those vocal cords are vibrating in men 110 cycles, women 220 cycles. They're sonicators. They are breaking up mucus into tiny little pieces, and then the exhaled air is expelling it out. And so that's a graphic representation of why singing in particular with a sonication of mucus further puts people at risk from this virus. And a big example, great example of that, probably most people have heard about, tragic example from Washington State, Saginaw County, well reported back in March, where a choir got together, 60 people, one patient with symptoms, only one. At the end of choir practice, I think it was an hour and a half or so, the 32 people had been infected, and they probably in turn infected about 20 others. 3 patients went to the hospital, 2 died. It was in a practice session where people were not particularly close together, but there was no air movement. The heater, the air conditioning or the air movement was simply not turned on that night. And so a good example of what can happen without masks, without distance, when singers are singing into a closed space. Next slide. This is a representation of a kind of a way to think about what is safe with respect to the things we can do to avoid the virus. And if you look along this upper aspect from left to right, you see low occupancy and high occupancy halves. And then with each one, you have the same 3 conditions, one of being outdoors with good ventilation, the next row being, or column being indoors, well ventilated, and then poorly ventilated. And then up and down on the left side is for the considerations of people wearing masks and in contact for a short time, wearing masks for a prolonged time of contact. And that's the 2 conditions which are further subdivided into groups that are either silent, speaking, shouting, or singing. And if you look in general, we're getting the green light for this is a pretty safe situation, and the red light for when this is not a safe situation. And the key concept here is, again, we have layers of risk just as we have layers of defense. If you're singing in a poorly ventilated high occupancy setting, that's down in the bottom right hand corner, don't do it. That's high risk. If you're silent, outdoors, well ventilated with a small number of people, you're at almost no risk. You can kind of estimate your risk. The higher it is, it will depend upon how many people there are, whether they're speaking, whether they're singing, whether they're shouting, and on ventilation. Layer these as you consider your risks, and you'll be in position to minimize them. Next slide. The last couple of slides here, and then I will start to deal with some questions, are going to set us up to talk a little bit about antibodies and vaccines. Let's go ahead and watch a 1-minute video here that gives some good visuals.
Antibodies will play a key role in beating COVID-19, but what are they and how do they work? Antibodies are proteins produced by the body, which form a crucial part of our defense against infection. On encountering the virus, the body switches to attack mode and rapidly creates antibodies from white blood cells to combat the virus. The antibodies combine to proteins on the virus itself to either neutralize it directly or prevent it from attaching to and entering the cells in the body, or they might bind to host proteins on the cells to shield them from infection. Once an infection starts, there is a race between the virus replicating and spreading and the body trying to limit its progress until it has built a strong immune response using antibodies. If the virus is faster than the immune system, the results can be fatal. We want to change this. By looking for antibodies such as those commonly found in recovered COVID-19 patients, we can identify those with specific protective effects. These antibodies can then be replicated and manufactured as medicines to rapidly neutralize the virus in severe cases or prevent the virus from infecting those at risk. These antibody therapies are complementary to vaccines or other approaches and will
That's
play
good.
a crucial part in defeating COVID.
And I wanted to show you that just to give you a visual idea. The antibodies are direct from vaccines, and also those that are synthesized, monoclonals, are intended to block that receptor interaction with the spike protein. They are antibodies to that binding domain. So if they are sitting there like a mask, they're keeping that spike protein from interacting with the virus. Last two slides, and then I'll start to deal with some questions. This is just the first part of a longer sonnet by Auden, and it's worth reading. They are and suffer, that is all they do. A bandage hides the place where each is living, his knowledge of the world restricted to the treatment that the instruments are giving, and lie apart like epochs from each other. This is a longer, you can go back. This is a longer piece of poetry. It's a sonnet, but I think the point is, traditionally and understandably and perhaps rightly, we think of medicine, we think of illness as isolating, and we think of the things a person with illness can do as very personal and pertaining only to themselves. Now, next slide. This pandemic, though, is in some ways is very different. Because we're not just vulnerable ourselves as individuals who can get illness. We're vulnerable as societies. We're vulnerable as organisms, as groups of people. And so how we do is not entirely dependent on ourselves and how we behave. It's also dependent upon our neighbors, nearly as much as ourselves. Last slide here. Next slide. So I'm gonna quiz Brad and Talitha in 1 second on these two strings of numbers up above. This lower string of numbers is just a reminder that if 3,000 viruses get into a cell and they each get out and infect another cell, that's now 9 million. And if those do the same, that's 27 billion. And if those do the same, that's 81 trillion. And this is all within 2 days. This virus is moving very fast. That's the power of logarithmic growth. These two strings of numbers are a little bit different, and I won't put them to the test here. I'll just tell you, if it seemed when this virus first came out that each person infected, on average, infected 3 others. That number is probably a little lower now because of some of the measures we've taken. But if one person infected 3 and each of them infected 3, that's 9, and 3 more is 27, and 3 more is 81. If it takes about 5 days to become infectious after you're infected, 5, 10, 15, 20, 25, 30, by the time you get up to 2 months, one person is potentially responsible ultimately for 1.5 million infections. Now let's say that person, after infecting 2 people, puts on a mask and doesn't infect a third. So instead of 3, he's only infected 2. But everybody else unmasked, undistances. That 2 infects 3 more, that's 6. They infect 3 more, that's 18, 54, and so on. After 2 months, 1 million people are infected. But look at the difference. Look at the difference. That's more than 500,000 people that are not infected because one person wore a mask. And that's what I mean in very specific terms about how we are our brother's keepers. If we avoid infection by taking mitigating behaviors and taking them seriously, then we have huge downstream impact. We may not be able to measure it, we may not be able to take credit for it, but it's a dramatic difference in how many people acquire the infection. And that, along with vaccines, is the way we beat this condition. Now, I have some questions that have popped up on the chat line. Do you want me to take those, Brad?
Yeah, am I off mute now? Yes, great. You know, Joe, we first of all, thank you for making it so clear. I didn't have any questions along the way, speaking as a layperson. We probably should have budgeted a little bit more time. It's a way of, you know, doing live presentations. Even if we were all in the same room, something like this would happen. So let's say that, why don't you take a couple, 3 questions, and then we'll roll right on into Talitha and I had one other suggestion for the folks at home, and that is, this is definitely one of those sessions you might want to revisit again after the day is over, because there was a ton of wonderful information, and thank you, Joe.
There are a couple of questions that are already up on the chat line, Lynn. One of them is, could you explain long-term damage to the lungs? And that's a wonderful question, and it really is a very fundamental biological question, because I've shown you that little picture which showed the sac of the lung right up against the blood vessel, where damage could result in leaking from the pulmonary compartment, if you will, into the bloodstream. Well, whenever there's damage anywhere in the body, if the general architecture is preserved, then healing is pretty good. If you cut yourself superficially on the arm, 2 weeks later, you won't be able to tell where it was, right? The environment of healing is so clear and so normal. It's such good scaffolding that the body's ability to replicate cells and to fill in the gap is pretty astonishing. And most organs are able to do that when there is scaffolding. But if you had a burn that destroys the local architecture, it's very difficult to get normal tissue to result, right? The scarring, it takes place because the body doesn't really have any scaffolding. It doesn't have any direction. And the same is true in the lungs. If you had only lost a few cells and the normal architecture was pretty well preserved, by a few, I might mean a few million, and we're talking about big numbers, but what is relatively a small number for biological purposes, then the body could repair itself pretty well. You might not notice any consequences. But if you lose the scaffolding, if you destroy a lot of those alveolar sacs, the healing will be with scar tissue. One of the slides I skipped was a CAT scan that shows how badly that scarring, it's like a burn to the lungs, how badly the lung tissue is left afterwards. And then, of course, it can't work very well because it needs that proximation, that very thin division between air and blood. And now you have scar tissue in there. So scarring of the lungs is a big problem. I don't think we appreciate yet how common it is and how bad it how commonly it is going to be severe, but it is a big problem, no doubt about that. I think we're only beginning to appreciate it. Another question came up was, how long is an asymptomatic COVID-infected person infectious? It's kind of a trick question because there's a period of peak infectivity, and then there's a long trailing period of declining infectivity. And so whether they were truly infected would depend upon whether they were masks and whether they were distanced. But there's no doubt that the infectivity precedes, in a symptomatic person, precedes them, the symptoms, by several days. And the CDC guidelines recognize that a person who is infectious could be infectious for as long as 2 weeks. So that's probably true of asymptomatic people as well, although their peak infectivity is clearly over within a week or so. Needless to say, it's hard to know the answer to this until you can study a whole lot of people that don't know they're infected to see how long the virus is recovered by serial exams. There was one other question. Is there time for that, or do we need to quit? Okay, we're done.
I think, you know, in the interest of time, we'll have to do just one more, but there was one that came early on while you were speaking. Should we rethink anything we're doing in light of the new strain that's now shown up?
That's probably the strain, the B117 strain from England. There are several mutations that have recently been recognized, one in Brazil, one in South Africa. And there are going to be more. I mean, viruses mutate all the time, and sooner or later a mutation is going to provide the virus a little bit of an advantage. The one we're talking about probably links that spike protein to the receptor a little more tightly, so it's less likely to fall off and more likely to infect. But it doesn't seem to cause a disease that's any worse. It doesn't seem to behave any more badly once it's in. It's just more likely to get in, and therefore it's that much more important that we use our masks and our distancing and our good ventilation to avoid getting it.
Thank
Thank
you
you very
so much. The comments are just reinforcing what we already knew, that this was super helpful. It demystifies it. It makes it clear why we should do those things that the medical community have advised. And here's hoping that the vaccine will be distributed widely and quickly, and we can get back to that thing which brought us together today, which is singing in community.
Okay.
Absolutely.
Thank you, Joe, so much. Thank you.
Joe.
Thank you. Thank you.
Thank you.